Hello, my name is Jack Bennett and I'm an international clinical trainer at the Interacoustics Academy. This presentation is all about the assessments for tinnitus and is intended as an introduction. We will be covering history taking, questionnaires and audiological investigations. First of all, history taking. It is understood that by the time a patient with tinnitus is presenting to a specialist, they have likely had frustrating or negative experiences with other healthcare professionals. This is why it's so important to use the history-taking process as an opportunity to truly listen to your patient. It is of course important to understand vital medical, social and family history information, and direct questions to obtain those answers are needed, but initially a clinician should employ techniques of active listening and allow sufficient time for this. At no point should the patient feel rushed. Active listening is a way of listening and responding to another person that improves mutual understanding. It is about the listener being present psychologically, socially, and emotionally. This process of active listening can benefit the clinician and patient in many ways. It can signal your interest to the patient effectively. It can help the clinician to understand and truly hear the patient's story. It can prevent the clinician from making premature hypotheses. It can reduce the incidence of later rising complaints. You don't have to think about the next question, which will block your listening. It allows you to calibrate the patient's emotional state and understand where they are. You're able to observe more carefully and pick up on verbal and non-verbal cues. There are 4 key skills in active listening. They are wait time, facilitative response, non-verbal skills, and picking up on non-verbal and verbal cues. Wait time is pausing during the conversation and consultation, and are used to focus the attention on what the patient is actually saying, rather than preparing the next question in your head. By giving patients a few seconds longer to respond, we provide them with an opportunity to think and contribute to the session without interruption. It also gives the clinician more time to listen, think, and respond more flexibly. A facilitative response is a small but powerful indicator to the patient that we are listening and interested in what they're saying, such as saying things like, "I see," or "Go on," or "Tell me more about this." Non-verbal communication are things like our gestures, our tone of voice, and our facial expressions, but also posture and position in the room. All of these can reveal something about our willingness to listen, and it's one of the most important non-verbal skills used to let patients know that we are interested in their problems, and that's eye contact. If we are pressed for time or speak in a hurried voice and only make fleeting eye contact, a patient will assume that they cannot or should not tell us about their problem in sufficient detail. Being aware of how the room is arranged is also important. It's not having any physical barriers like a computer screen between you and the patient allows for more effective communication. Through active listening, we should also be able to pick up on verbal and non-verbal cues from the patient. And if we practice this skill, we can more effectively use those to understand our patients. Finally, however, the clinician should also seek to obtain direct answers to the history of the tinnitus and underlying medical conditions. We should seek to understand about the onset of the tinnitus, about the course and the movement and the change of the tinnitus over time, about the duration of the tinnitus that the patient experiences, about its character. What are the specific components of the tinnitus? Is it loud? Is it quiet? Does it pulse? What are the other sort of features of that tinnitus? Are there any associated symptoms with the tinnitus? Are there any things that make the tinnitus worse, an aggravating factor? Are there any things that make the tinnitus better, any relieving factors? And what is the psychological impact of the tinnitus on the patient? So that's history taking and using active listening to truly understand our patients. Let's now have a look at questionnaires. There are many questionnaires reported in the literature. and they all have their own particular aims and focus. Using them helps to facilitate your discussion with the patient and find key areas to focus the rehabilitation on. It can also help you set a benchmark that can be returned to later on as a map of the progress. Here are 3 key questionnaires which are well reported in the literature and have lots of norms and good instructions. The Tinnitus Functional Index, the Tinnitus Handicap Inventory, and the Tinnitus Reaction Questionnaire. But, as tinnitus also affects other areas of someone's life, it's also relevant to have a body of questionnaires that might help you further understand the knock-on effects, such as insomnia or depression. So here are some examples of other useful questionnaires: the Hospital Anxiety and Depression Scale, the Insomnia Severity Index, and the short-form Quality of Life Questionnaire. Those questionnaires listed here are in English, but the Tinnitus Handicap Inventory has been translated into Portuguese. And the Tinnitus Functional Index has also been validated against that in this paper here. You can see from this figure that the two have a very strong correlation. This indicates that they are appropriate and can be used in clinical practice in Portuguese. As tinnitus is a symptom and not a condition itself, it's important to discover if there's any underlying otological pathology. Understanding if there's a hearing loss and what form that takes is essential, as is understanding any vertigo or imbalance, as these can lead to a number of diagnoses with very different management and prognoses. Discharge and or pain in the ear can also direct management towards treating an underlying infection or injury. However, we can also use more specific testing to form a deeper understanding of the tinnitus itself. These are things like pitch matching, loudness matching, assessing tinnitus masking levels, and assessing the residual inhibition. First, let's focus on the specific and special considerations that we should take into account when testing the patient's hearing. Other than just assessing their hearing levels, which may be very important when considering the management with hearing aids or tinnitus maskers, the goal here is to set a baseline for further comparisons and to test for any neurological involvement. We should use a similar test battery as other audiological assessments, but we may need to modify our methods at times. In the example of pure tone audiometry, we may need to use pulsed or warbled tones, as pure tones may be difficult to distinguish from the patient's tinnitus. However, we should be aware that this does mean that there's a negated factor in terms of the frequency specificity of that stimulus. We may also need to look at high frequency testing, as the hearing loss may actually be in frequencies which are higher than the standard frequencies that we would test in normal audiological testing. We of course should be cautious of high intensities. Many people with tinnitus find that loud sounds exacerbate their tinnitus. However, we should also be selective in our testing of uncomfortable loudness levels, or ULLs, as assessing these may help us understand the limits of testing for other tests further down the line. We should be very cautious with these. Speech testing. This can indicate retrocochlear involvement, but again we must be cautious about testing at high levels, especially if there's a hearing loss. We need to be cautious about exacerbating the tinnitus of the patient. When testing tympanometry, our standard 226 tympanometry can help us understand the condition of the middle ear, and we may even consider wideband tympanometry for further and deeper understanding of the middle ear pathology. But we should also consider eustachian tube function testing, and especially patulous eustachian tube testing. As eustachian tube dysfunction or patulous eustachian tubes are a common cause of tinnitus and may be treated and managed in a very different way to other forms of tinnitus. Acoustic reflexes can also indicate retrocochlear involvement. but we should be very mindful of the stimulus intensity used during acoustic reflex testing, both contra and ipsilateral testing. We should make sure that we're not testing above levels that may exacerbate the tinnitus or make it worse. Using a system like the Titan, which has automatic gain control, can ensure that you do not present an overly loud stimulus into a smaller ear canal, for example, as it regulates the stimulus to match the desired intensity. So when approaching our tinnitus assessments when using a standard audiological battery, and we're trying to understand the neurological components that may be contributing to the tinnitus, we must be careful not to exacerbate and make the tinnitus worse, and we may need to find other ways of assessing the neurological components that we're interested in. Outside of the standard test battery, we can seek to have a further and deeper understanding of the tinnitus itself. The first test I'd like to use as an example is pitch matching. By using the multi-frequency feature, you can test at more specific frequencies and identify the pitch or pitches at which the tinnitus is heard. We would normally do this at 10 dB sensation level, or 10 decibels above the threshold of the patient. As you can see here, in this example, we've matched the tinnitus at 4,470 Hz. This is obviously not one of the frequencies we would test in a standard pure tone audiometry. Subsequent to pitch matching, we can then move into loudness matching. And here, again, using the same example, we can actually use smaller step sizes to make fine adjustments to the level and discover the loudness at which the tinnitus is heard. So rather than the standard 5 dB step size, I can change it to a 2 dB step size for a slightly finer and more detailed assessment of the loudness. Further to this, we can also look at minimum masking levels and residual inhibition. Now, these tests are not often used in clinic as they take quite a long time to complete, although they are well established in the literature. However, this paper, a new method for assessing masking and residual inhibition of tinnitus by Fournier et al., discusses some new methods to speed up this testing in order to give useful prognostic and diagnostic information. First of all, the minimum masking level. This is the minimum level of a masking noise needed to make the tinnitus inaudible during the stimulus presentation. In this diagram, you can see that the masking and the tinnitus are heard at the same time. That is to say, there is a simultaneous presentation of masking. The masking is a broadband noise, and it is turned up until the tinnitus is no longer heard by the patient. The first level at which this occurs is defined as the minimum masking level. Then we can look at the residual inhibition. Now this time, we're looking for the minimum level of a masking noise needed to make the tinnitus inaudible in between stimulus presentations. That is to say, that if we provide masking sounds with a gap of 1 second in between each masking sound, how loud does that masking sound need to be in order for the tinnitus to be inaudible during the gaps in between the presentations of the masking? This differs to the standard or traditional method for understanding residual inhibition, but in the paper mentioned earlier, it does speed up the process and makes it potentially more relevant to be used in tinnitus assessment clinics. So, in summary, it's really important to focus on these 3 key areas. We need to understand the person as well as the tinnitus, and we need to employ methods of active listening in order to enable this process. Using questionnaires helps us to benchmark and monitor the progress of the tinnitus. And understanding the underlying otological diagnosis is very important, and we need to use diagnostic tests for this. Thank you very much.